Welcome to Bipolar She. I'm your host, Janine Noel. Before we get started, the content of this show does include suicide and suicidal ideation. If you are ever in need of immediate support, please dial 988 Suicide and Crisis Lifeline. I believe in the healing power of writing and speaking our mental health stories in all their raw details. So let's go. The following is part 2 of my interview with Dr. Susan Swick. Dr. Swick is a clinical psychiatrist and the director of Ohana, a Center for Child and Adolescent Behavioral Health at the Community Hospital in Monterey, California. Today, Dr. Swick breaks down the Dialogic method of therapy that was developed in Finland as they set out to find better care for schizophrenic young adults. By bringing in the patient's family, friends, and community members into therapy with the patients, those managing schizophrenia had higher compliance with their medication and overall better health outcomes. At Ohana, Dr. Swick and her colleagues are using this dialogic method with youth suffering from a range of mental health issues and seeing promising results. I am so inspired by Ohana's work and how family-centered care could change the landscape of mental health treatment for both the young and old. Please enjoy part 2 with Dr. Susan Swick. I'd love to circle back to families and their involvement.
Yeah. Yes. So you asked about dialogic before. So dialogic work is a mode of working with a family that grew out of a team in Finland that was treating patients with schizophrenia. In Finland, where they have a very comprehensive national health system, they have good services for patients with more chronic mental illness. They were finding that despite having such a strong healthcare system, patients were still frustrated with medications, going off medications, ending up in emergency departments, getting hospitalized, stabilized, going back home, and the cycle would repeat. And they decided to try a new approach, which was not just to keep crossing our fingers looking for medicines that were effective without side effects, and instead to try to engage the system that existed around these patients. Now, most of them were 18 to 25. But they often were living at home, or if they weren't, their families were very involved, particularly when they became symptomatic and ended up on the streets and then in an emergency room. Often when they were in crisis, the whole family system would be in crisis. Often their support system would get angry at the patient, frustrated with the patient, that somehow it was their fault. And the clinical team in Finland decided they wanted to try to find a different way of responding to the crisis. And they created this intervention that they called Dialogic. It's because it promotes dialogue. All of the clinicians sort of step out of being the experts who are going to tell everyone what to do. And instead, they are experts who listen. And they invite the patient and the whole family system. And this is the broadest concept of family. So this is who has been involved in the life of the patient in the recent past. So it's often, who do they live with? Who are they partnered with? Who in their family is talking to them on the phone a lot? So parents, siblings, if there's grandparents, aunts, uncles, or cousins, whoever is actively involved in their lives, maybe trying to help them achieve health and stay healthy, maybe just as loving, supporting friendship connections, but that whole cast is involved. And then their clinicians are also part of the system. And they all essentially sit in a line. And the facilitator, there's a facilitator, and then there's the clinical team that sit in a different line, sort of facing the family system. And the facilitator invites everyone in the family system to explain why they're here today and who is missing. And they make sure that no one is abusive or vindictive or inappropriate, but generally speaking, what they want every person to say is their experience of what is happening. Maybe a parent would say, my child has schizophrenia and he keeps stopping his medication. He says it makes him too sleepy. He gets better in the hospital. But once he's home, after a few weeks, he's frustrated with feeling sleepy, and he stops his medication, and they eventually tell the story of how it affects them, that they're very worried, that they're frustrated, that they wish they could do more, they feel powerless, et cetera, et cetera. And they run the line, and eventually everyone is really just explaining a very human story of what it's like to love someone and not be able to help them the way you'd like to, including the patient. And then the reflecting team, which is the clinical team, closes into a circle. And everyone in the reflecting team, who often is assigned someone in the big family system, reflects back what they heard. They don't make a diagnosis. They don't offer a synthesis of it. They literally say, I heard the patient's father say that he was feeling heavy-hearted, worried, and frustrated and guilty that he can't help. And they may expand a little, but it's about reflecting the facts and the feelings. And the family system just listens. And then when the reflecting team is done covering every single person in the system, they open up their line, and the family system runs their line again and says how they're feeling, having heard their story just reflected back to them. That's it. That's the dialogue. It takes like 90 minutes to 120 minutes. Is a long time. But employing this response to a crisis in Finland, the patients that got this intervention, in addition to the rest of the normal care that they were getting, over the next year, they had dramatically lower rates of being rehospitalized, of going on and off medications, and actually they ended up being on lower doses of medications overall. So they weren't over-medicated. We now use this dialogic approach for families that present to us sort of in the state of crisis, but beyond psychotic illnesses, we're agnostic about the possible diagnosis. We just use it when a family is really struggling. Often, maybe they don't mean to vilify, but identifying the patient as the problem, not being able to all be lovingly connected to a patient that's trying to build skills and facing frustration themselves. It's an extraordinary thing to witness, a family that may feel very stuck, including the clinical team who may be very identified with the patient and frustrated with the family that keeps, pointing fingers. It really helps to expand a sense of compassion for the family, for the patient, and for oneself. And that's true, I think, for the family members and even for the patient. And then a sense of connectedness and understanding that seems to be very helpful for being able to face a challenge that isn't necessarily simple, that isn't going to be a quick surgical fix. It's not going to be getting a tooth pulled, but it doesn't have to be hopeless either. Being able to bear something that has some difficulty and uncertainty in it alongside people you love and be appreciated and appreciate others for what they bring seems to put so much more gas into everyone's tank that the course of illness in the child and the feeling of connectedness and resilience in the family system is dramatically different. So we have a goal this year that every family in our care will actually have at least one dialogic session, not just waiting for crisis, but trying to enhance connectedness and listening and validation. And also, I've come to believe that a marker of mental fitness is a capacity to view the world outside of you, the feelings and world within people you care about, and the world inside of you in a clear-sighted way, being able to actually really perceive it very clearly and bear it even when it's uncomfortable, which is easier said than done, and that a big piece of doing that is being able to focus on what is it I will be able to do to manage this reality, and who am I connected to that cares about me at my best and at my worst, that sees the beauty and dignity in me at my best and at my worst, and that is so powerful. And the capacity to see those things, to be able to be in those kinds of relationships with others, and it equips you to then maybe take the kinds of actions you might need to try that are part of adaptation. Sometimes the actions we take don't fix things right away. Sometimes they might even make them a little worse, and you have to correct course. But if you're paralyzed because you fear that you're going to disappoint someone you love, or you're proving that you really can't do anything right, it makes adaptation almost impossible. It's paralyzing. So I think that might be one of the little nuggets that we get to in a dialogic session, where it kind of clears the air and a family gets to sort of see the love that is there and see that everyone's feeling the pain of a shared challenge, and it's no one's fault. And in fact, they may have a lot of the resources they need to face this together, even if they can't fix it. So that's a central piece of what we do. We also do less labor-intensive interventions, where we do a lot of education for parents. We have some of our prevention programs are raising resilient children, raising resilient teens, where we actually offer some, hopefully, illumination of what it is that's happening developmentally during early childhood, the school age years, and adolescence. What are the active ingredients in parenting? Not being perfect, but essentially being able to stay connected to the idea that if you're attuned to your child and you're still creating some routines and clear expectations, and you have rules that you expect people to follow, if you can hold both of those sides, which again, simple but not easy, that actually is what kids need. And it changes a bit from childhood to adolescence to young adulthood. So we offer online or in-person little seminars. We have a 6-week workshop for parents that want a little more detail. And how do you actually communicate with your teenager when it's so different than it was when they were little? We have programs for grandparents. We have programs for military families. We have a lot of military families in the region where our community hospital is, because we have the Naval Postgraduate School and a Defense Language Institute. So we have a lot of families that come here for 1 or 2 years, and they face very distinct challenges as families. So equipping parents to understand development, and they're the experts on their child. They're like the Library of Congress on their child. And we bring some expertise on child development and what makes for effective parenting. And we try to make that as accessible as possible for families in our community. And then also roll that out for families that are in our clinic, that are in care and treatment. So even in our highest levels of care, we have a residential program where kids can come for up to 6 weeks. It's an unlocked inpatient unit, so it's more like camp or short boarding school, where kids are doing a little bit of school every day and a lot of skill building. But we have family day in all of those programs. The families, we help them get FMLA so they can spend a full day with us at least once a week. And they're learning about what skills their child is building. They're figuring out what skills they might need to be able to stick with it with their child, to complement what their child is doing. They don't have to praise it by compliment, the other kind of compliment, where they sort of support it, and to not undo the work their child is working hard to learn how to do, and to celebrate their child. Their child's doing the same work kids are doing in school. They're learning who they are. They're learning how to work hard at things. They're cultivating the skills that they need to thrive. So we bring families into it because we think it will accelerate recovery, but also really be foundational for this to be a part of building the skills to flourish and not just recover.
And it looks like just within a year, you're having some really good outcomes also.
Yeah, we are having some good outcomes. First, I'll say I was really surprised that we found that many insurers have been really receptive to what we're doing, because we are involving the family, despite the fact that that's typically not been something that's covered in American healthcare. But there's an interest in trying to actually improve outcomes for kids, not just put them someplace safe when they're in crisis. And we found that those kids that maybe are facing the most intense symptoms, who are going to hospitals and maybe to longer-term residential programs, we've been able to take good care of in our residential program in 2 to 4 weeks. They can graduate to our day program for another 2 to 4 weeks, and then to outpatient care. And we're measuring outcomes not just in the symptom range, but with mood and anxiety symptoms, with abstinence from substance use. A lot of our kids will be managing substance use disorders along with mood or anxiety symptoms. But we're also tracking outcomes that are more functional. How are they doing with school attendance? How are they doing with their sense of being future oriented, with knowing what they want to actually work on that's meaningful for them, whether it's academic or it's about different kinds of skill building. Not every kid has to go to a 4-year college, and helping kids actually build their sense of who am I going to be and having it be really authentic is important to us. And so we track sort of mental health outcomes, sort of fitness outcomes. How are they doing with the healthy habits, sleep and exercise, nutrition? Again, not trying to set people up to feel like they have to be perfect, but to pick the area that matters the most to them. And we're tracking outcomes within the family system. How's communication going? How's the level of conflict? And how's the sense of connectedness within the family? We're having good outcomes right now. We're feeling like we're on track. Not everything will be good, and we will like to have bigger numbers and a longer follow-up period so we can start saying how we're doing with a greater degree of certainty. But right now, it's looking quite promising. We're feeling good about it.
Absolutely. It's very inspiring. And the outreach resources that you have as well are really impressive. If you just go to your website, there's so many great question and answer forms there for anyone worried about a child and their mental health. It's a great site. And there's some Zoom events that you can do from anywhere, right?
Yep. The workshops I was mentioning before, the Raising Resilient Children and Teens, they're free and they're virtual, so you can do them from anywhere. We also have videos that if parents want to do it on their own time, they can just watch. We've started to create hopefully more digestible videos. So instead of having to watch a full movie about this, there's little short videos that are on smaller topics like avoidance of bedtime in younger children. So little challenges that we'll talk about in a 2 to 5 minute video. And we also have an Instagram page. And I say this and I feel like I'm 80 years old. But we have an Instagram page that our prevention team updates. And we like to try to put content there that's actually direct to adolescents and school-age kids, but that they might want to show their parents. We have a youth advisory committee that's made up of about 18 high school students from across our county who come in once a month, and they get to respond to content we're developing, our new programs, both for treatment, but also for prevention, and tell us what they wish their parents knew, what they wish teachers knew. So they inform some of what we put out there. And we like to get feedback on what is helpful. But when we can put content out that's digestible for youth and that they might actually look at or talk about with their parents, that's sort of super powered, because then you get kids and parents talking about drugs and alcohol, talking about social media, also talking about relationships. And those things that are critical to youth development, adolescent development, those things that might be the areas of risk where we want to keep kids connected with adults as they're facing risks and challenges that they're not facing them alone. So we have a lot of content out there. So check out Instagram, as she says, as an 85-year-old woman.
Oh, well, thank you so much. You just wish every child could experience a program like this. So it's exciting work that you're doing.
Well, I appreciate it. And I'll say, if we do our job well, that maybe in the next decade, we will have sort of hit upon a set of services that are effective for treatment when there are illnesses that need treatment, but also we've been able to articulate in pretty digestible ways practical strategies that can help parents help their children build great mental fitness. So parents know how to teach their kids to brush and floss. So we'd like to have mental health be as simple as dental health for parents, in which case every child could experience some of this. And maybe the numbers of kids that need treatment or care will be smaller. So that's our big ambition, is to help nourish healthier communities.
Great. Well, thank you so much. It just looks like a gorgeous campus down there, too.
Well, having spaces that help you appreciate the moment you're in, even if it's a difficult moment, it's really important. It's actually part of good health and good mental health. So we really tried to encapsulate that in our physical campus so that patients, families, and our staff have that experience when they're at work. And we can be inside or outside with sunshine and beautiful plants, be ready to keep our own batteries charged as we're doing the work that we've chosen to do.
Absolutely. I just learned so much, and I can't wait to put this episode out there.
Well, I appreciate you. I'm so impressed with you and your story and your resilience.
Oh, thank you.
You're taking your experience and really brilliantly turning it into a chance to make things talk aboutable on a broad level.
Oh, thank you.
Yeah.
Thank you.
I appreciate you. And thanks for having me on.
Thank you for coming on. Please consider Bipolar She a work of advocacy, getting important stories to those who need them. Please like us and rate us and leave us a review wherever you find your podcasts, and especially on Apple Podcasts. Find us online at bipolarshe.com or at bipolarshepod on Instagram. And thank you, as always, for your support.